from the Center for Leprosy Diagnosis and Research, Faculty of Medicine, University of Colombo, to deliver his presentation.
Good afternoon all, I am Primesh Vijaypura, a research assistant. The title of this study is the comparison of quantitative real-time PCR and Seale-Nielsen smear microscopy for the diagnosis of leprosy. This study was carried out under the supervision of Dr. Nilanthi Senanayake, consultant microbiologist and director, Center for Leprosy Diagnosis and Research, Faculty of Medicine, University of Colombo. Introduction. Leprosy remains a major public health concern in many parts of the world, including Sri Lanka. One of the main challenges in diagnosis is the low sensitivity of conventional methods such as slit skin smear microscopy, which is a widely used diagnostic technique for detecting Mycobacterium leprae in clinical samples. Since Mycobacterium leprae cannot be cultured, laboratory confirmation relies heavily on microscopy. Quantitative real-time PCR or qPCR offers a more sensitive approach to detect and even quantify DNA of Mycobacterium leprae in clinical samples. The main objective of this study was to compare the quantitative real-time PCR and Seale-Nielsen smear microscopy for the diagnosis of leprosy. Figure 1.1 and 1.2 shows oil immersion magnification under a light microscope of Mycobacterium leprae. Methodology. 36 slit skin smear specimens received from suspected leprosy patients from September 2024 to September 2025 from the Central Leprosy Clinics at National Hospital of Sri Lanka and Colombo South Teaching Hospital were subjected to slit skin smear microscopy by Seale-Nielsen stain and a probe-based quantitative real-time PCR. The slit skin smear microscopy was performed by identifying suitable sites such as earlobes, elbows, or active lesions, and a small slit was made by using a sterile scalpel. Then the tissue was scraped and spreaded on a clean glass slide and allowed to air dry. This smear was heat fixed and subjected to the Seale-Nielsen stain. This stained smear was examined under oil immersion for acid-fast bacilli. The smears were graded according to the grading of microscopy results described as in the Manual of Skin Smears for Leprosy, Basic Manual for Leprosy Control Supervisors and Laboratory Technicians. The real-time PCR procedure was performed by extracting DNA from the collected clinical sample, followed by the preparation of the PCR mix and the addition of the DNA template. This was loaded into the PCR machine and allowed to run. Results were interpreted and reported. A probe-based quantitative real-time PCR targeting the RLEP gene of Mycobacterium leprae was performed to detect bacterial DNA. Each run included an internal amplification control to assess inhibition and extraction efficiency, and a beta-globin primer set to confirm human DNA quality. Results. Of the 36 total samples, 13, that is 36.1%, were AFB positive, and 23, that is 63.9%, were AFB negative. Of the 36 total samples, 18, that is 50%, were qPCR positive, and again 18, that is 50%, were qPCR negative. Of the total 36 patients, 21, that is 58.3, were multibacillary, and 15, that is 41.7, were paucibacillary. Of the 13 microscopy positive patients, 10, that is 76.9%, were multibacillary, and 3, that is 23.1, were paucibacillary. Of the 18 qPCR positive patients, 12, that is 66.7%, were multibacillary, and 6, that is 33.3%, were paucibacillary. The bacterial load observed in our qPCR runs showed a median value of approximately 2.6 into 10 to the power 3 bacilli for multibacillary patients and 1.3 into 10 to the power 2 for paucibacillary patients. Of the 36 patients, 100% successfully amplified with the beta-globin primers, confirming adequate DNA quality and the extraction of PCR inhibition across all reactions. Figure 1.3 shows a bar chart representing mean bacterial load in multibacillary patients and paucibacillary patients. And we can see very clearly over here that multibacillary patients had a very high mean bacterial load. To conclude my presentation, qPCR is more effective than slit skin smear microscopy in diagnosing leprosy. qPCR detected higher levels of paucibacillary patients which were tested negative by slit skin smear microscopy, indicating its future use for diagnostic purposes, especially in early leprosy cases. Therefore, we recommend qPCR as a very important diagnostic tool for the detection of early stage leprosy patients. Thank you.
Thank you, Mr. Vijaykuda, for your excellent presentation. Now the floor is open for questions.
There are 3 areas of concern, and now first is that whether the sample size is adequate or not. Secondly, when we are talking about 2 tests, you are comparing 2 tests for diagnosis.
Sorry, sir, can you be a little louder? I have a little trouble hearing.
Right. First one is that we talk about the sample size, which is seems to be not adequate for this kind of tests. Secondly, the comparison of 2 diagnostic tests. So you have looked at the sensitivity but not the specificity. So those are the 2 areas you have, when deciding what is the best diagnostic test or even the screening test. Both aspects need to be considered, sensitivity and specificity, right? And the third one is that you have not talked, although somewhere you have mentioned that this seems to be more expensive. In the conclusion, you have not stated whether the new method which you have found more sensitive is cost effective or whether it is feasible in our setup. So those are the 3 areas of concern I think that you need to address. Thank you.
Yes.
Can I ask one question?
Yes, madam.
How was the diagnosis of PB and MB made? Because according to your presentation, in the SSS negative, in the SSS positive group, there were 3 patients with PB disease.
Yes.
But according to the diagnostic criteria, if the SSS is positive, it cannot be PB. So why was that this discrepancy?
The classification was taken from the patient's ticket, so that was given by the clinicians. Madam,
Right.
can you repeat the question again? Can you
if-
repeat the question again?
So the SSS was done at your unit, right? You did not use the slit skin smear positivity that was given from the Central Leprosy Clinic or the Colombo South, or was the slit skin smear staining done at your unit?
Yes, so we also collected a smear, and then we also stained it, and then we cross-checked it with the results at the Central Leprosy Clinic, and then those results were the same.
Yes, because if your result is contradicting with the other lab's result, because it seems that there is such a contradiction, because the clinical diagnosis of PB, now you have a positive smear.
Yes.
That means the clinical diagnosis of PB will have to be changed to MB, and the treatment will have to change. I don't think you are getting my point. Clinically, they diagnosed PB, but when you did the slit skin smear, that was positive. So that criteria, according to criteria, that person who was diagnosed as paucibacillary disease will have to be reclassified as MD. And so, if there is a discrepancy between your lab result and the other lab result, I think the clinicians will have to be notified and the classification changed.
Oh, right. So the classification, the interview was done before performing this test. That's where the confusion is. So the classification PB or MB was taken before performing the laboratory test.
Thank you.
This is the last presentation of this session, and with that we will conclude the session.